For those of us just joining on the recording, hello and welcome to the Rutgers Roundtable on Aging and State Policy in New Jersey, hosted by the Hub for Aging Collaboration at the Rutgers School of Social Work. This event is part of an annual Roundtable on Aging series hosted by the Hub for Aging Collaboration. Thank you for joining us today. My name is Natalie Pope, and I'm the Senior Program Coordinator at the Hub. On behalf of our team and our presenters, we are glad to welcome partners and colleagues on aging across New Jersey and beyond to this event spotlighting the exciting work on state-level policy on aging happening at Rutgers. It is now my pleasure to introduce Dr. Emily Greenfield, professor at the Rutgers School of Social Work and director of the Hub for Aging Collaboration, for welcoming remarks. Due to a recording issue, we join Dr. Greenfield as she introduces the event as part of the Hub's multi-year series of events in honor of Careers in Aging Month.
Last year in 2025, we did a roundtable on engaged research on aging in New Jersey. And now in 2026, it's our great pleasure to have this roundtable and you all with us on aging and social policy in New Jersey. Next slide. So today's event is to spotlight our Rutgers-based work on social policy and aging in New Jersey, really wanting to reflect the diversity of disciplines and units that are involved in this work, how this work spans sectors, with higher ed being one of many, public sector, higher ed, nonprofit, industry, et cetera, to advance the future, the 21st century of policy on aging. So next slide. So just to show you the breadth of the presentations that we have today and where they're coming from, we have units within our Chancellor unit of Rutgers Health, as well as presentations stemming from our Chancellor unit in New Brunswick, featuring the Center for State Health Policy, a School of Public Health, the Institute for Health, Healthcare Policy, and Aging Research on the Rutgers Health side. And on the Rutgers New Brunswick side, we have the New Jersey State Policy Lab supporting some of this work, our Rutgers Hub for Aging Collaboration, and the School of Social Work, and two presentations stemming from the Edward J. Bloustein School of Planning and Public Policy. Next slide. So in addition to thanking our presenters, we want to thank you all for coming today. We've had actually just reached 200 registrants who signed up for today's event, and we're happy to have a large number of you here with us live this morning. 92% of the registrants hail from New Jersey, which is wonderful given the New Jersey-centric focus of this, and we welcome our friends and colleagues from other states as well. And about a quarter of us are affiliated with Rutgers, which really shows the broad cross-sectoral interest in this work at Rutgers on aging and social policy in New Jersey. Next slide. So here's how it's going to go down for the rest of our time together. We've divided the program into 3 segments, and in each segment, attendees can choose between one of 2 presentations, which will be delivered through breakout rooms. And it will help you get into breakout rooms with Zoom controls for those who need that, no problem. Our first segment is going to focus on MAID, medical aid in dying, and then another presentation on economic challenges. Segment 2, direct care workforce and state grants programs on disabilities and aging. And segment 3 on Medicaid long-term services supports and a multi-sector plan for aging in New Jersey. We kind of broadly organize kind of a track A that's on health services related policy and track B on kind of a more aging in society, more broadly kind of policies. So we hope you are able to select into the breakout room that piques your interest the most. With our last 5 minutes or so of today's program, we'll have some closing announcements really highlighting future events coming up in the next 2 or 3 months for further learning and engagement together. And then we'll ask when you exit the Zoom room, you should get a brief, like a 1-2 minute satisfaction survey to give us some feedback on this event, which we really do look at carefully when planning our future programming. So with that, we'll go to the next slide. And I'll turn it back over to Natalie to introduce our first pair of breakout options. Thank you.
Great. Thanks, Emily. All right. So yes, we are glad to introduce our first segment of presentations here. We have in breakout room A1, we have a presentation on medical aid in dying MAID in New Jersey by Dr. Elissa Kozlov. New Jersey is a pioneer on this legislation, and we are very fortunate to have Dr. Kozlov conducting research on its implementation locally and nationally. This talk will provide key insights into this work. In breakout room B1, the presentation is entitled Economic Challenges for Older New Jersey Residents by Doctors Anita, Franzione, and Cathy Rowe. Their session will highlight a university community partnership to leverage data from a statewide survey of older adults to dig into economic challenges facing older adults in New Jersey and implications for policy. So when we open the rooms, you will be able to select which talk you wish to attend. If you need any assistance navigating to your preferred presentation, please let us know in the chat, and our team is here to assist you. All right, Emily, let's go ahead and open up the breakout rooms. Enjoy your sessions, everyone.
Thank you so much for joining us, and thank you for your interest in this breakout room. So we're going to give you a very brief overview of several studies that we've been conducting at Rutgers. I see my colleague, Dr. Luce, is in the room, which I'm really excited about because she and I have been doing this work together largely. So my name is Elissa Kozlov. I'm an assistant professor at the School of Public Health, where I also direct our concentration in population aging. So a little bit of background on medical aid in dying. Medical aid in dying is a legally available end-of-life health care in a growing number of states. So you can see over here, New Jersey, it's been legal since 2019. Right now, over a quarter of Americans are living in MAID legal states. The red states indicate that they're considering it in their legislative agenda. Light blue is where it's currently legal. So MAID is a process by which a person who has a terminal illness with less than 6 months to live may choose to end their life through legal medical means. A person will request a prescription for medication that will cause death from their physician. In most states, a physician will have to verify that the patient has less than 6 months to live and will have to confirm that the patient is not impaired in their judgment around this decision. Then a second physician will have to review the medical records and confirm the diagnosis. In many states, patients must make two separate requests before a physician will give them the prescription. But just because it's legal doesn't mean that everyone has access to it. And so today we're going to talk a little bit about, once a state legalizes MAID, the real policy question becomes how do health systems operationalize it, right? So the state says it's legal, but then what? Who's going to actually do the clinical work of MAID? Because every provider, every institution has the opportunity to opt out of ethically contentious care. And why MAID feels hard in practice is there's a lot of reason there. There's a lot of tension in MAID. Some people think that it's respecting a patient's autonomy while also protecting, but then we also want to protect people who may be structurally, socially, or medically vulnerable. This isn't a hypothetical concern. People are always worried about subtle pressure, feeling like a burden, or having inequities shape choice. For supporters of MAID, it's framed as compassionate relief from intolerable suffering. For opponents of MAID, it crosses a moral boundary about the value of life, regardless of prognosis or suffering. And this isn't really a question that can be solved with research or data. It's really a values issue and an ethics issue. And we're not really going to get into that today because I am a researcher. I am trying to approach the topic of medical aid in dying from a place of studied neutrality. So everything that we talk about in today's talk will be data driven, empirically driven, because my premise as a researcher is it's not for me to decide if it's ethical or aligned with my values. It's for me to understand how it's actually being rolled out and what's happening with real world data. So, patients really depend on systems and providers for information. And so once it's legal in the state, there's a lot of questions about what happens in practice. And part of our talk today is really looking at how those institutions are making decisions about medical aid in dying. So let's get into the talk. Today, at Rutgers, we are trying to get some more empirical data to help drive the policy discussions around medical aid in dying. And specifically today, we're going to talk a little bit about who is using MAID, who knows about MAID and wants MAID, and how are organizations handling medical aid in dying. So let's start with who is using MAID. So this was a study where every state that has made legal has to report their use data publicly. And each state has their own system for reporting. And so we conducted this study a few years back. So at the time, we only were looking at 9 states where MAID was legal. And we were looking at their publicly available data on who was using MAID. And essentially, we were aggregating all of those publicly available reports on MAID to try to get a sense of who's using MAID across the country. Um, and what we found was that overwhelmingly, the population who's using MAID are older adults, white older adults with high educational attainment, cancer diagnoses, and almost all of them are enrolled at hospice at the time of medical aid and dying ingestion. And there are some reasons for that policy-wise. Um, and so we're really seeing a pattern emerge across every state. Um, and when we publish, 95% of the deaths by MAID are from non-Hispanic white individuals, and it accounted for 89 of the prescriptions. So some states report MAID deaths, some states report MAID prescriptions. So we tried to understand that. And 64% of the deaths are of people older than 65, and over 70% of the deaths are from people with a terminal diagnosis of cancer. Um, and so this is really painting a very clear pattern about who is using MAID. But what it's not doing is telling us if this is because of preferences, right? Is this the demographic who wants to use MAID? Or is it because of issues of access? Is it because of issues of systemic inequalities that are really swaying who has access to MAID? So we wanted to keep digging a little bit deeper to better understand this. Um, I will just show you a little bit. These are the trends over time. So as MAID laws mature, you see an increase in use, which is pretty expected and pretty universal. You see some dips over here, likely due to COVID and some other things happening in the country. Okay, so again, let's try to understand, is this a preference thing? Is this just that white older adults with cancer tend to be the ones who want MAID, or is something else going on? So the study objectives on this was to understand what people know about MAID and its legality in the country. Um, and we also wanted to ask people about their preferences of potentially using medical aid in dying if terminally ill. And we mapped out the differences by race, education, and geography. So what we did was we utilized a national online convenience sample. So we used a company called Cloud Research, and we recruited 3,227 adults, and we intentionally oversampled people living in MAID legal states, people over the age of 60, and racial and ethnic minorities. And the reason we did this was to facilitate subgroup analyses and try to understand what was going on in these subgroup populations that can be kind of hard to recruit. And we asked them via survey, via online survey, is MAID legal in the state in which you live? Is MAID legal anywhere in the country? Would you be interested in using MAID, if you were diagnosed with a terminal illness? And what we found was that over half of US adults did not know whether MAID is legal or not in the country. And even in legal states, many people were unsure. So I want to just show you this breakdown of states. So the dark blue is people saying, I don't know. The question is MAID legal in your state? Dark blue is I don't know. And you'll see, with the exception of Oregon, Oregon, by the way, is the first state to legalize medical aid in dying, and it's been legal in Oregon since 1998. So Oregon, the most the most often correct state, was still only hovering at around 50% of people knowing. In Oregon, where it's been legal for well over 20 years, Oregon's the only exception to people overwhelmingly not knowing if medical aid in dying is legal. And then, the correct answer is yes, it is legal. And then the light blue is incorrect. No, it is not legal. I want you to note that in New Jersey, look at how many people knew that it was correct and knew that it was legal in New Jersey. We were the worst. We were just over 10% of people in New Jersey correctly identifying that MAID is legal in New Jersey, even though it was legalized in 2019. And we did this survey, I believe, in 2023. Um, we also asked, would you be interested in using MAID if you had a terminal diagnosis? And what we found was that a substantial proportion say that they would consider MAID. And there were some differences by race, education, and religion, but no group is at zero interest. And this really matters because I think many people assume, clinicians especially, assume that patients will bring up MAID if they're interested or care about MAID. But if patients don't even know that MAID is legal, silence doesn't necessarily mean a lack of interest. It may mean a lack of information. And so this is the would you personally consider pursuing MAID? And the darkest block is definitely or probably would. And look at that. In almost every state, that is the overwhelming majority of patients say that they would definitely or probably consider pursuing MAID. And when you break this down by race and age and education and ethnicity, again, that dark block is definitely or probably. And so, look, you'll see there are some differences here, right? We are seeing differences, but you'll see, oh, wait, hang on. I think I got the colors reversed on this one. But what you'll see no matter what is that a substantial amount of people are definitely or probably interested in using MAID. So it can't just be a preference thing that's going on that's accounting for the racial and ethnic differences in the MAID use data. Oh, I'm sorry. Yeah, I did inverse it here. So the dark one is definitely or probably would not. And the lightest color is definitely or probably would. And so you'll see in almost every group, definitely or probably would represents the largest proportion of respondents. Okay? So we're seeing that people from lots of different educational backgrounds and racial and ethnic backgrounds are definitely or probably interested in pursuing MAID, but those people are not showing up in the use data from the states. So this makes us really ask the question, how do patients learn about MAID, right? We know that they don't know that MAID is legal. What are clinicians allowed to do within their organization? What do they feel comfortable doing? And what institution you happen, it seems like what institution you happen to be in as a patient may determine what care is available to you. So organizational policies around MAID really matter. After MAID is legalized in the state, it's up to the individual health systems and doctors to decide what to do with the law. I have one colleague who is a physician in a major health system, and I asked, and he has prescribed MAID. He is comfortable prescribing. And I asked him, well, what is your institution's policy on MAID? And he said, I don't know. And I said, well, do you feel uncomfortable prescribing MAID given this lack of institutional policy around it? And he said, I'm operating on a don't ask, don't tell basis. And that feels really surprising to me that there's this legal healthcare available to people and organizations aren't even talking about it, let alone making it publicly available or known to their patients. And this particular provider told me also, they have to tell me they want it. I will not bring it up. So how are we how are we supposed to get the word out about MAID? If, especially in New Jersey, only 14% of people knew or 12% of people knew that MAID was legal here. And yet it's entirely up to the patients to figure out if MAID is the right choice for them and they don't even know it exists. Um, what we saw in our first study was that 87% of MAID deaths in the US occur among hospice enrolled patients. Hospices themselves can opt in or out of MAID participation. Historically, hospices have been pretty against MAID. Some of the larger governing bodies of hospice and palliative care are anti-medical aid in dying. They say it's antithetical to the care that they provide. Um, and so given these facts, we wanted to understand in a different study how hospices are disclosing their position on medical aid in dying. And so we essentially we used a sample of 724 hospices around all of the 11 US made legal jurisdictions in 2024. And we scoured their websites to try to figure out if they had a public-facing policy on medical aid in dying. And when available, we extracted it and coded it to better understand what the MAID participation policies were if they were available. And the results here are very clear. Only 5.5% of hospices, 39 out of 724, had a public-facing MAID policy. And I throw up the New Mexico and California states in particular, because in those states, there is a law that mandates that hospices publicly disclose their MAID policy. So even when there's a law telling you you have to disclose your MAID policy, there is an incredibly low compliance with that law. We were able to determine that for-profit hospices were less likely to publish policies than nonprofit hospices. And so, right here, I think we're seeing that transparency is the exception, not the norm. Patients often find out a hospice's stance on MAID after enrolling when time is limited. We've had stories from MAID prescribers in New Jersey of hospices finding out that their patients were pursuing MAID and unenrolling them from their hospice program because they did not want to be a party to a medical aid in dying death while the person was enrolled in their hospice care, which is a really troubling issue in terms of continuity of care for patients. And, when you're thinking about patients at the very end of life having to navigate re-enrolling in a new hospice, finding a hospice that's MAID friendly when there's no data available online, it's a very high burden on patients to pursue this themselves. When the policies did exist, they were unbelievably vague. So, in those 34 or so hospice policies, 38% didn't clearly state whether the hospice participated in MAID, 46% didn't say whether the physicians could prescribe, 79.5% lacked a clear protocol for how patients were to initiate MAID, 56% didn't clarify whether hospice staff could be present at bedside during MAID ingestion. So what this is telling us is that even when there is some sort of hospice policy, it's really unclear what the hospice policy is on MAID if they're not kind of, stating these very basic tenets of being a hospice that allows or does not allow MAID. Transparency is really foundational to informed decision making. So I approach all of this research in terms of patient-centered care and informed decision making. It does not matter to me whether a hospice or a provider or an institution prescribes, is supportive of MAID or does not engage with MAID. What matters to me is that that information is clearly available to patients so that patients can make informed choices around their end of life care. It also points to this idea that legal mandates without enforcement, right? In California and New Mexico, they're supposed to be publicly disclosing, and they're not. And so there's really an important role for clinicians and institutions to start to increase transparency around how their institutions and how their clinical care handles MAID when MAID is legal in their state. I want to wrap up a few minutes early because I'm guessing there may be some questions, and I'm aware that we only have about 4 minutes for questions. So I'm going to throw up my information about the master's degree in public health with a focus in population aging in case anyone is interested. And I'm going to open the floor up to questions now.
All right, so good morning. I'm Anita Franzione. I am professor here at Rutgers at the Bloustein School for Planning and Public Policy, where I teach primarily public health and health administration. Cathy, you want to introduce yourself, and then I'll go straight to the slides.
Sure. I'm Cathy Rowe, Executive Director of New Jersey Advocates for Aging Well, and one of the team leaders for the Lifelong Strong New Jersey campaign and call for a multi-sector plan for aging.
Okay, dokie. So I'll go to the next slide, hopefully. Why doesn't this go?
See a lot of friendly
Here we
faces in
go.
this room. It's
Here we go.
nice.
It's going to be a little slow. So I just want to lead with how Cathy and I got together. I've have many, many years of experience in working in healthcare at all levels. And I specifically got interested more in aging and aging policy and aging issues and providing services to this population. And I happened to go to Cathy's annual conference and was so taken with her, I literally walked up to her and I said, would you like to teach
Believe
my
me,
class?
it's sad that she left.
Are we okay?
Yeah.
All right. So, I said, would you like to come and talk to my class? Because one of the classes I teach is public health and aging. And what I'd like to do is bring in people who are in the field, who are doing this at various different levels. So I have clinicians, I have transportation, and Cathy, I brought in about policy. So that's how we started our relationship. And with that, a number of students always say, oh, this is so interesting. Can I do something? So that's where we started to do. So with starting out with this, so there was a number of projects that Cathy and I have worked on, but this is the main one that we want to talk about today because this was so exciting. Okay. This was the New Jersey State Policy Lab funds research, looking at the needs of the community, looking at bringing students together, etc. So when this came out, I went to Cathy and I said, Cathy, would you be interested? And Cathy goes, yes, because I mean, well, it was a great fit. They had finished doing their survey, their state survey, which Cathy will talk about, okay, on over 60 people in New Jersey and what their needs are, what their challenges are, etc. She says, I need people to start looking into what was being said. So that's how we started. Why doesn't this? Here we go. I'm sorry, it is so slow. Okay. So here it is. Okay. This is ours, and I'll go through it because that's the focus of this. But there's some other reports, the other projects that the state health policy has done. And later on, when you get the slides, you'll actually I have the links in these so that you can see them, including this. Okay. All right. We're going faster. So it's the economic challenges for older New Jersey residents. And here we are. This is what the report looks like. I'm so proud of it. Okay, I have it not only do I have it electronically, but I have it physically, so I walk around with it. But this is what it looks like, and it said it was released in January, and was said, Cathy can say it again. We're very, very proud of what we have accomplished, and it has gotten a lot of views and a lot of interest. So I really think, just to reiterate what Emily says, I think New Jersey is really on the cusp of making policy changes and for the older population. Okay. So here's the executive summary. Okay. This, just to give you what it looks like and what we had written. So what we wanted to do is to recognize the affordability challenges. That's what we were seeing over and over when we were looking at the data. Okay, so that was the table of contents to show you what we did. We analyzed the trends, the challenges. We also looked at other states, and we think that was really important to show what other states are doing. There is the emphasis of making a multi-aging plan for aging, a multi-sector plan for aging, and bringing in all different people, all different backgrounds and things that they could bring in. So that's why we then went to other states and said, this is what other states are doing. And we looked at states that were similar to New Jersey. as best as we can. So there it is, the link. And here's the conclusion. Okay, as I said, it's the perfect time to address this. So really, really thank you everyone for being here. Okay, let us start talking about this. Let us looking at housing. Let us looking at transportation. Let us looking at utilities. And what we have seen is most, in addition, it's not only just for low income people. Okay, what we really saw a lot was this middle income, the 50 to 75 $1,000, and how they are trying to struggle in meeting the challenges, the economic challenges of being in New Jersey. So here is the links that I wanted to show you: the Senior Connect, okay, to promote digital equity, okay, supporting aging in place, and then the role of community rating in long-term care. So you can see the breadth that the state health policy does, and also the breadth that we do at the Bloustein School for Planning and Public Policy. I don't want to, but this is what we do. We have all disciplines, and it is a great place for all of us to come together to be able to address this. So Cathy was so wonderful to really put this in about her own experience, and I think you can address a lot of questions to her to expose students and interns to the aging field. Again, that is why I bring people to my class, raising the profile for NJAAW, okay, about the policy, about the survey. We're now looking at maybe doing a second one or another one, taking the research to a deeper level, and that's the expertise that we bring to relevant policy, looking at the priorities, especially now with our new governor. Okay. And then last but definitely not least, support the Lifelong Strong New Jersey campaign. So with that, here is our email. So I really, really stress that you can come and talk to me, talk to Cathy, email me. I'm always available to work with outside of Rutgers and bring in and looking at the expertise that you could bring in and the expertise that we can bring in. So thank you. And with that, I'm going to stop sharing.
All right. In the sake of time, we might still have some people finding their way back, but let's go ahead and orient to our next segment of sessions. And thank you again to our fantastic presenters for getting us going this morning in our first segment here. So in breakout room 2A, we have updates on direct care workforce policy in New Jersey. This is presented by Dr. Renée Edwards. And this talk will highlight Rutgers' involvement in cross-sectoral partnership and to advance direct care workforce policy. Their work involves partnering both with state leaders as well as working with and through a statewide coalition. It serves to strengthen New Jersey's long-term services and supports for aging. And so in breakout room 2, B2 rather, we have New Jersey state grants for age-friendly and inclusive healthy communities. This is presented by Rebecca Martin and Shannon Lyons. This session shares an overview of 2 innovative state-based grant-making programs, one led by the Division of Disability Services and the other by the Division of Aging Services, both in partnership with the Rutgers Bloustein School. This work aims to support local action toward healthier and more supportive and inclusive communities for people with disabilities and older adults. So we will now open the breakout rooms, or maybe a moment, I'll check in with Emily to make sure we're good to go. But in just a moment, we'll be opening those rooms. And as with before, we'll do our best to promptly get everybody into their desired location if you need any assistance. So I hope you have a fantastic second segment here, and off we go.
Okay, welcome everyone. Thank you for joining the session. I am Renée Edwards. I'm speaking from the Heldrich Center for Workforce Development at Rutgers, but the work that I'm talking about today is really collaborative, involves a ton of partners across New Jersey. So we included state agencies, employers, advocacy organizations, and community partners. So I was actually really happy when I heard that the audience for this roundtable was more diversified than what they originally told us, which was that it would be largely Rutgers. So I was really happy to hear about that. So today I'm briefly going to talk about how direct care workforce policy intersects with aging policy, and specifically in the state of New Jersey.
So I'm going to use a workforce pilot as an example that we actually implemented here at the Heldrich Center. But the focus will really be on how cross-sector collaboration generates policy insights. So what do we learn from doing this type of work, and how does that apply to the state? And how can that strengthen aging services in New Jersey, and I would argue other states as well? Let me see if I can make things work here. Aha. Technology isn't usually on my side, so that's why I'm surprised. So why is this an aging policy issue? Direct care isn't always talked about as an aging policy issue. When we talk about aging policy, a lot of times the focus is on things like healthcare, housing, Medicaid programs, but all of those systems rely really heavily on the direct care workforce. So the people providing hands-on support to older adults, people with disabilities, I work a lot in that area as well, in homes and communities. So in New Jersey and a lot of other states, long-term services and supports, often called LTSS, they depend really heavily on home health aides and other direct care workers. So if agencies cannot recruit and retain workers, it becomes a lot harder for older adults to remain in their homes and communities. So while we often talk about this as a workforce issue, it really is also an aging policy issue. So the stability of the workforce is really directly connected to the success of a state's aging in place strategies. So that's why this becomes not just this broader workforce issue, but really specifically an aging policy issue. So the state knew this, right? The state had identified these persistent workforce shortages and all of these sort of issues in the state of New Jersey. And they launched a pilot initiative focused on certified home health aides, or CHHAs. The goal for this, well, the pilot was actually supported through federal funding, money follows the person funding, which was intended to help strengthen community-based care systems. And the goal of the pilot was to expand and strengthen the CHHA workforce pipeline. So this included three main components. There was a training scholarship pilot that supported individuals entering CHHA training, paid for that training for them, and also offered stipends along the way to help retain individuals throughout the training process and into employment. At both 6 and 12 weeks of employment, they were also given a stipend. There was a specialized training component in dementia care and mental health first aid to give them incumbent CHHAs additional credentials. And there was also a mentorship model designed to support new workers, specifically immigrant workers, and also to improve retention. So there was more of a focus on the community of ESL workers, pairing new CHHAs with existing CHHAs. The Heldrich Center was engaged as an implementation and evaluation partner. So the state was also really focused on this as an opportunity to learn about system level barriers that affected the workforce, which, next slide, good segue, Renee, that's why we got involved, right? So the state wanted to fully understand what those barriers were and why they existed. And to do that, we really need research and evaluations. What are the pain points? Where are things showing up? What are the structural challenges for this workforce? So here at the Heldrich Center for Workforce Development, which is part of Bloustein, we've worked on workforce policy and research for more than 25 years, a lot of policy engagement. So in this in this project, our role included helping design the pilot models, supporting implementation, and then also a separate team led conducting the evaluation. And together, both teams really focused on structural barriers and research around the workforce in New Jersey. So an equally important role in this, though, was the Heldrich Center and the implementation team serving as a neutral partner that could convene different stakeholders. So that's really important in this work, right? We'll talk about that a minute more in a second. But workforce challenges, they impact so many different sectors. So we have in this particular challenge, right, in CHHA workforce and direct care workforce, you have aging services, you have healthcare systems, you have workforce agencies, you have employers, and centers like ours and universities at large can sort of contribute by bringing those perspectives together, providing research capacity, providing the evaluation, and facilitating sort of all across those different buckets. So shared problem solving across all of the organizations. So our model, our cross-sector partnership model looked like this, right? You have the states sort of on the top. You have other agencies, community-based organizations on the bottom, but addressing these workforce shortages really requires coordination across all of these different actors. So you have aging services agencies, health departments, labor and workforce agencies, licensing bodies, advocacy organizations. So each of these groups sees the system. I like to say it's a different view from each window, right? They see the system from different vantage points. And that's good because when you bring all of those agencies together and all those actors together, you get a more complete sense of what the view actually is. So many of the insights from this project came from bringing all those perspectives together and identifying where is the system misaligned? Where are they not lining up? Where are the gaps? For example, recruitment efforts, training capacity, employer hiring needs, regulatory requirements, all these things sort of overlap and interact in ways that aren't always visible when the policies are designed, right? You don't always see those things. It's the boots on the ground. That's when all of those things become something that you really see. So I like to call this from implementation to policy intelligence. Let's think about this not from designing the policy perspective and then figuring out where the challenges are, but let's figure it out from let's actually do it. Let's implement this thing and then figure out like how do we get smart about our policies? So implementation reveals all these system barriers that are difficult to see from a policy design perspective. And through this project, a lot of those came to the surface. We found that contracting and procurement processes really slowed the speed at which programs could scale, programs like this. Employer hiring capacity, certification delays, all of these things kind of limited how quickly recruitment efforts could translate into jobs. We had a lot of applicants, but the employers themselves could only seat so many people in a training. They had to often wait. CHHAs had to wait quite some time to be certified in order to actually work. Digital literacy barriers affected not only the candidates, but also employers navigating the systems, reporting systems, application systems. Mentorship worked well when it was built into the program structure, but if it was optional, CHHAs have a lot on their plates and they're doing a lot of things. So doing something extra is extra, right? It's difficult even when they're being paid to do it. Reporting systems sometimes limited the ability to monitor the outcomes in real time. Everything had a lag because it had to be manually inputted into a system. So these are the kinds of insights that are valuable because they show how policy design and operational on the ground realities really interact. So then implementation kind of becomes this process that can inform future policy decisions. So then how do we do that? How do we take our policy smarts now and actually put them into relevant recommendations? So those implementation insights really translate into several different emerging policy considerations for New Jersey. And again, I would argue other states as well. But workforce initiatives may need stronger digital infrastructure support so that participants and employers can navigate the systems easily. Recruitment efforts and marketing, they have to be aligned so that your recruitment is happening. You have an influx of people applying for programs, but employers don't have the capacity to hire that many people all at the same time. So you have to be careful about spreading things out, or just being very strategic about how recruitment and employment can actually overlap. And then retention strategies like mentorship, like I mentioned, they're more effective when they're actually embedded in program design rather than sort of added as an option. Interagency coordination can be really critical when workforce initiatives overlap with all of these regulatory systems. So for us, the Board of Nursing was instrumental in helping us educate our partners about how to streamline individual certifications. All the partners were sort of doing their own thing. Some were working really well, others not as well. The Board of Nursing was, we had a webinar and brought everyone together, all of our agency partners and the Board of Nursing, and they were able to sort of walk through the process. These are the types of things that work well. These are the types of things that kind of slow the system down. So having that sort of intersection, like bring everyone together, let's figure this out, really helps. And stronger workforce data systems, I think a lot of states struggle with this, right? But they can help policymakers better understand their recruitment, retention. What are the trends? What are the workforce trends over time? So these are some of the things we learned along the way that were really signals that can inform broader workforce policy decisions. A lot of these policy challenges here were structural challenges that are sort of also, they were beyond the pilot, but they were highlighted by the pilot, right? So recruitment is often emphasized. Everyone talks about we need to recruit more CHHAs, but retention is really a major concern. We had no shortage of applicants. We had more applicants than we could actually deal with, right? But the issues were translating those applicants to into employees and then keeping them. So it wasn't as much the pipeline that was an issue. It was those sort of, it was the translation and the retention issues. Wage structures and reimbursement systems, these all influence employers' ability to stabilize the workforce. A lot has been said about this, certainly not a New Jersey problem. Workforce equity is a really important issue. Someone brought this up in my last session. A lot of direct care workers are immigrants and women of color. Language is so important. A lot are English second language speakers, and so we translated tons of documents so that they were able to more easily make that bridge, but it's difficult. So a lot of these challenges highlight, why these workforce issues sort of remain central to aging policy conversations. What does Rutgers do for my Rutgers folks? What is Rutgers' role in this sort of aging ecosystem? So in this ecosystem, I think universities, not just Rutgers, but universities can play a lot of useful roles. One is research. I think that this implementation program landed in a good spot because before we even started, we were doing research. We were trying to learn about the other things that states are doing. We are trying to learn about, what's happening in New Jersey. We were trying to learn, where do CHHAs or someone who wants to become one, where do they go to learn about it? We had some really simple research questions that really played a big role in this. Rutgers and universities can provide research capacity, evaluation infrastructure. They can help bring together stakeholders from different sectors. That was a really big part of what we did. They can help translate implementation lessons into policy insights. And for public universities in particular, I think there's also this sort of state tie that is, really kind of translates into a service mission, applying research and analysis to strengthen our public systems in our state and support state decision making. That I think is really strong. So, it's not just about this particular project, but I think projects like this kind of illustrate how academic institutions can contribute to policy development, but also engaging these community and system partners. And that's a really big part of it. So again, those partners, right? There's a lot of opportunities here for cross-sector collaboration. And I think deeper collaboration is needed. So these could include research partnerships that explore workforce trends, student engagement in research and analysis. We had a lot of that here. Data sharing to better understand workforce dynamics. Pilot initiatives like this one that test new workforce strategies are super important. And then broader collaborations that connect workforce policy with aging policy planning. I think so important and a really big lesson out of this. Because ultimately this direct care workforce has to have sustained engagement across all of these sectors. That's what I have for you today. I'm so excited for the discussion.
Thank you. And thank you all for being here. It's exciting to see so many people who are interested in hearing about the grants program. I'm trying to slow myself down because in the last one, we heard that that's important. And I tend to be a fast talker. My name is Rebecca Martin, and I'm a licensed social worker in New Jersey, and I work as a senior research specialist at the Bloustein School of Planning and Public Policy Center for Urban Policy Research in the Public Health Policy Working Group. It used to be Environmental Analysis and Communications, just recently changed, so the slide before. But anyway, so now I oversee two grant programs, which are the Inclusive Healthy Communities and the Age-Friendly Grants Program. And Shannon is here with me today. She has over a decade of experience working with age-friendly communities, and she works with me on the Age-Friendly project. And so she's going to also help me tell you about all of this today. So thank you again for being here. So the two grant programs are really special because they provide capacity building and technical assistance. And I believe that they're unique programs throughout the country. We haven't been able to find other programs that are working in the same way. They both fall under the New Jersey Department of Human Services. The Division of Aging Services received funding through the American Rescue Plan Act, which has funded this round of New Jersey age-friendly communities or age-friendly grants programs. And there are two different types of grant programs, which I believe Shannon will tell you about later in the age-friendly. Then but it's a one-time thing, so far as we know, from the ARPA funds, and we'll conclude in June of 2026. On the Inclusive Healthy Communities side, this is a grant program that focuses primarily on disability inclusion, and it takes a policy, systems, and environmental change approach, and that is funded through the Division of Disability Services, and is currently in its fourth cohort in 2026. So I'll turn it over to Shannon to tell you about the Age-Friendly Grants Program, and you can tell me when you want me to switch the slides.
Okay. All right, great. It is great to see you all. It's great to see so many familiar faces, some people part of the program, and we've been working together. So good morning and TGIF. So we'll start with a description kind of with the numbers of the New Jersey Age-Friendly Grant Program. As Rebecca said, this program is funded with ARPA money, and it was funds were initially awarded in 2024. There are two types of grant programs that, so there's two sets of grantees, I should say. There are 10 project grantees, and these are communities that were, I think for the most part, familiar with age-friendly work or had some experience doing age-friendly work in the state, and they wrote an outline of a specific, like a demonstrative project, something they wanted to change, involving transportation, local community programming, or some sort of systems change. I also want to mention that these grants were awarded following the publication of the Age-Friendly Blueprint in 2024. I know there are a couple people, I think, on the call this morning who were involved in the Age-Friendly Council on the state level. And gave feedback in developing the Age-Friendly Blueprint that was published by DHS. So this grant program came out following the Age-Friendly Blueprint publication. There are 10 project grantees, as I just mentioned, and 28 community planning grantees. Many in that group are
cities, boroughs, basically municipalities. There are a few organizations that are going through this process, a YMCA or some other sort of community organization. They're conducting a needs assessment. They're looking at the needs of the community, getting feedback, and then applying to the AARP Age-Friendly Community Network and developing an action plan. So those are sort of the 3 points involved in the Age-Friendly Community Planning Grant Program. All of the funding concludes June 30th. All the work will be done by that date. And then the grantees will submit a report basically to the state on the work that they have done. So next slide. So we wanted to share a little bit about what our role, Rebecca and I, as training and technical assistance, the training and technical assistance program, that this is part of the grant program. All the grantees receive or are able to participate in training and technical assistance sessions. It's a little different. The project grantees receive individualized as technical assistance, and they receive one-on-one meeting time with Rebecca or both of us together. We've done that a few times. And really just get feedback on how it's going, how their program is going, what other kind of assistance they might need, other training, other ideas for training that might be beneficial for how they're going to complete their program. The community planning grantees, so those other 28 grantees, have had combined TA sessions. Actually, now we're meeting with them on a more individualized basis as we get closer to the end of the grant period. But they also receive training webinars that are specific to the grant program. And then we're also going to have public webinars that are available to all the grantees and the public, and hopefully share with IHC some of that training as well, those grantees. They also all have access to the AARP training portal resources. So that's been another help. And also in a collaboration with Ohio State University, they have been able to participate in their training and certificate program as well.
Okay, so now I'm going to tell you a little bit about Inclusive Healthy Communities, which we've been doing since 2021 and are in the 4th cohort. And a lot of what has happened with the age-friendly communities has sort of built from the idea that this is a really strong way to support grantees in the state who are doing work that is new and challenging and exciting. And a lot of what we come from with IHC is this, and I didn't mention it earlier, but both of these programs have a no gotchas approach, which means that we as the technical assistance and capacity building support are working with the grantees. They're encouraged to tell us the challenges that they're experiencing and the barriers that they're encountering, because we are there to support them in growing in whatever ways they need to be the most effective in these projects. And really, they have a strong ability to connect across the cohort, which really helps them to provide peer support and growth as well. So IHC focuses on policies, systems, and environmental changes for people with disabilities and increasing disability inclusion. And as we know, older adults and people with disabilities often benefit from a lot of the same kinds of changes and inclusion in community. So I think this is relevant. We even have one grantee who is specifically focused on aging with a disability, both people who have had disabilities lifelong and are now aging, and then people who are aging into disability. So there's a lot of crossover between the two areas of interest. But when focusing on policy, systems, and environmental change, what we're really looking to do is to create a lasting change that's going to stay with the community beyond the grant period. And that can be challenging your own internal policies and how you do things to support people, whether you're a program or a business or a store location, like how are your own policies really enabling inclusion for everyone? Or whether you're building systems, perhaps with other providers, networking with other people so that you can provide a stronger continuity of care. And then finally, we support environmental changes, such as, capital projects that would change environments in support of the other parts of the initiative of the program. And we have, through the course of this grant, funded 55 initiatives with 38 unique lead grantees, which means, of course, that we've had a number of grantees who have done multiple cycles. Often, people throughout their first cycle will do all of this data gathering and learn all of these interesting things that they had no idea were challenges in their community, and then apply for a second round of funding that will expand upon what they've done in the first. And it's been a really great program so far. And one of the things that it's spun off is some other groups that are looking toward making policy systems changes. And this includes the Access Nature group, which has been really advocating and kind of become a coalition in South Jersey to change access to nature for people with disabilities. This program has had a number of areas of interest and expertise. So we've had people focusing on nature and gardens. We've had municipal, county, and civic engagement projects as the leads. We've also had safety and emergency preparedness, aging with disabilities, as I mentioned, partnerships in arts and recreation, and we find often mental health comes up, mental health access with our communities. And then finally, inclusive health care access. And so it's a really exciting, broad amount of things that are focused on. I did want to identify that we do encourage the grantees to create white papers or presentations that they can do to show all the things that they're learning as they're doing this work. And so some of the things that have come up are the ways that benefits can impact and keep people with disabilities from participating as thought leaders who are compensated for their time and expertise. We've found that EPA regulations, which are very important for from an environmental protection perspective, can sometimes be so strict that it can really limit groups' abilities to make environmental spaces accessible. And so that's a lot of what Access Nature has been working on in terms of their advocacy to try to, in places where these regulations wouldn't have a negative impact on the environment, making sure that they can make these adjustments so that they will be able to be more inclusive. And for example, what I'm trying to say here is, there are different kinds of stones you can bring into the area that maybe aren't indigenous to the area, and so won't necessarily harm the natural area, but might be prohibited by law. So there are things like that that they're advocating about. And of course, some of the things that have been happening with DEI have made it really hard in our diverse and wonderful state of New Jersey for people to advocate in the way that they need to and speak about the projects that they need to regarding the importance of including people who experience other sorts of marginalizations as thought leaders in these projects. And finally, one of the things that I think is really important, which I haven't mentioned, is that all of these projects encourage, well, not just encourage, they require that people with disabilities are thought leaders on the projects. They are encouraged to do that from beginning to end. But that really is an important part of the projects. And a lot of times as people start to build their coalitions of advisors with disabilities, they realize that the project they initially proposed doesn't completely line up with what actually is needed in the community. And then we work with the grantees to revise the way that they want to do their approach, because the most important thing to us in this work is that it's being engaged in authentically in a way that's really going to create lasting change to systems. I've put the QR code here, which will give you a digital business card for me, but it has our website, which I also have listed here, but I knew you wouldn't be able to click on the link, so I wanted to give you an easy way to get there. So I'll leave it up for a second while we ask if you have any questions.
All right. Hi, everyone. Welcome back. All right. So we have done 2 sessions today. Thank you all so much for staying with us and for your active engagement in the conversations. It's been really wonderful meeting you all and going over this exciting content together. So we are now glad to go ahead and introduce our final 2 presentations here today. So let me make sure our slides are updated. Yes. Okay. So in breakout room 3A, we have Medicaid waiver for long-term services and support in New Jersey, presented by Dr. Mandi Spishak-Thomas. This talk will present findings exploring the health and aging in place impact of policy changes for managed long-term supports and services in New Jersey. Let's see. Oh, I see people are already putting their breakout rooms in the chat. Fantastic. You know the drill here. So, yes. This is also known as MLTSS. MLTSS is the flagship program to support older adults at greatest economic, social, and clinical risk as they age in their homes and communities. So that's 3A here. In room 3B, B3, excuse me, we have Toward a Multi-Sector Plan for Aging in New Jersey, and this is presented by Dr. Emily Greenfield. This session shares the origins, motivation, and the next steps for a cross-sectoral effort to position New Jersey as the next state to adopt a multi-sector plan for aging, which is a national movement to strengthen and broaden state policy action and public-private partnerships toward a better future on aging. So we have someone in the waiting room. Okay, so we will now go go ahead and move toward opening the breakout rooms as soon as they're ready. And as with the last few times, please let us know in the chat and we'll be glad to help move you around to your preferred session. So enjoy, and thanks again so much. We're looking forward to seeing you back in the main room for closing remarks.
So great. I am Mandi Spishak-Thomas. I am an assistant research professor at the Center for State Health Policy here at Rutgers and the Institute for Health, Healthcare, and Aging. I'm going to share my slides. Okay. Great. All right. So thanks for joining. As I said, I'm Mandi. We at the Center for State Health Policy are the primary investigators for Medicaid's 1115 waiver evaluation. So today I'm going to be talking a little bit about our relationship with Medicaid, New Jersey Medicaid, how that came to be, a little bit of history. Then I'm going to share a little bit about New Jersey's relationship with the waiver and with managed long-term services and supports. I'm going to share a little bit about our findings from the first waiver evaluation we did and a little bit about how this relationship is growing and what the future looks like for us. So first, this all started a very long time ago. We just celebrated our 25th anniversary actually at the center. And it all goes back to 1999, where SCOTUS required Medicaid programs to focus on rebalancing, basically. So the move from institutions to community-based services for people with disabilities. And Susan Reinhart, who was the original director of the Center for State Health Policy, spearheaded CMS's technical assistance efforts to help states navigate the shift toward promoting community living for those requiring longer duration support. And this whole relationship has really been a durable and a trusted one, basically because of CSHP's ability to bring data and evidence to bear to inform program planning across a menu of policy domains. And so this also includes, of course, strategies to care for older adults on Medicaid, but our relationship actually spans a variety of populations. So maternal health, housing supports for previously unhoused people, as well as people with disabilities, and then, of course, with aging. So a little bit, a very, very condensed timeline about how this started with the waiver specifically. So in 2011, when Medicaid accountable care organizations were established, we were assigned the key analytic role. And that sort of set the stage for, in 2012, state Medicaid officials contracted with CSHP to evaluate its Medicaid Comprehensive 1115 demonstration program, which is also a federal mandate for states who participate in 1115 waiver demonstrations. And this launched a major transformation of long-term services and supports, which provides enrollees who are aging or have disabilities in a managed care structure. And then most recently, CSHP also has been collaborating with the state on a body of research, and this is primarily focused on the impact of homelessness in the Medicaid population. And in that as well, we have a focus on older adults who've previously experienced homelessness or are at risk of experiencing homelessness for a variety of reasons, including needs for activities of daily living, et cetera. So the shift to managed long-term care. So New Jersey is actually one of about 23 to 25 states who have managed long-term services and supports. And we made that switch in July of 2014. The program operates within the comprehensive demonstration waiver, the 1115 waiver. And it was designed to help income-eligible individuals living with chronic medical conditions in need of personal assistance and higher levels of care. The goal really of the MLTSS program is to make or keep people independent and living safely in their community. So I'll highlight a couple programs and policies that are in place in the MLTSS program that are specifically focused on that. There's caregiver supports, there's also nutritional supports, and then, of course, as I mentioned before, there's housing supports. A little bit of the benefits overview if you're not familiar with the MLTSS program in New Jersey. It provides a variety of things from physical therapy to residential modifications like grab bars or accessibility upgrades, also respite services for people who are being cared for in the home. We'll talk a little bit about some changes to that program, vehicle modifications, home delivered meals, personal emergency response systems. It's a real variety of services. And so as our role as investigators with New Jersey's 1115 waiver, our goal was to really see, okay, you've implemented this MLTSS program. How is this actually impacting people who are living in New Jersey and accessing these services? And this took place ending in the year 2022, and we evaluated the 10 years before that. So we're really looking at this period of time from about 2012 to 2022 to look at some very high overarching outcomes. So things like avoidable hospitalizations, inpatient hospitalizations, both avoidable and otherwise, also focusing a little bit specifically on nursing home population and also people with behavioral health diagnoses. So our main research question asks, what is the impact of including long-term care services in the capitated managed care benefit on access to care, quality of care, and mix of care settings employed? And then looking at those differential impacts for those groups of nursing facility residents and beneficiaries with behavioral health diagnoses. We hypothesized that expanding Medicaid managed care to include long-term services and supports will result in improved access to care and quality of care, and also reduce costs while allowing more individuals to remain in the community instead of institutions. So these are our kind of like high level takeaways. And here we're seeing that the long-term care population has grown steadily since 2011, and the composition has shifted from the majority beneficiaries residing in nursing facilities to the majority residing in HCBS, home and community-based settings in 2022. And I have a nice figure actually on the next slide that I'll show you where you can see how that's grown over time. For the home and community-based service population, we found that MLTSS was associated with a small decrease in emergency room visits, and also we found a statistically significant decrease in hospital-wide readmissions. So that's for people who were inpatient for, potentially a fall or some other event, and then they are able to not be readmitted to the hospital. Lastly, for the nursing facility population, we found lower avoidable ED visits and overall inpatient hospitalizations and a higher rate of recommended care for people with diabetes. So overall, we're seeing some really good improvements and things that we'd want to see in this population. So here, as I said, is a figure showing the percentage of new Medicaid long-term service and supports users who received their first services in the community over 2012 to 2022. And you can see here that this percentage has more than doubled over this time period, from 25% in 2012 to almost 60% in 2022. We also know that this is in line with a lot of older adults' preferences, right, which is to remain in the community for as long as possible, or what a lot of us call aging in place. This is just a little bit more about our results, but I'm kind of going to skip ahead because I really want to focus on what we're doing next. So just to give a little bit of background about how we make these decisions in the evaluation. So for this first evaluation, you could tell that we were really focused on these sort of overarching outcomes, the classic outcomes that you would think. So the hospitalizations, the emergency room visits, the kind of big ticket items that are very costly to Medicaid. And while that's all well and good, we used very rigorous causal analysis. I think that also we did not feel necessarily that we were fully capturing the experience of older adults in New Jersey, and we kind of wanted to take a more mixed methods approach for the next waiver evaluation. And so here, I'll highlight some of the changes to the MLTSS program. So in our conversations with New Jersey State Medicaid, which as their partner are quite frequent, we'll have these meetings and we'll talk about how our evidence from the last waiver impacts the future policy in MLTSS in New Jersey. And so we're looking at three key places of changes. The first is with housing related services. The second is with nutritional supports. And the third is with caregiver supports. And these are all focused on improving quality of care and efficiency associated with managed care and improving critical services to the community through HCBS services. So the housing supports specifically are focused on individuals transitioning from an institution to the community, individuals at risk of institutionalization who require a new housing arrangement to remain in the community, or individuals transitioning out of high risk or unstable housing situations. And a lot of the housing support services are focused on housing navigation supports. So they're building out a whole department in Medicaid to manage this group of people, both aging and otherwise. Also, the home modifications that I mentioned before, so accessibility upgrades. We also know I'm a social worker by training. I've had a lot of experience discharging patients from the hospital to their homes, and someone will tell you they have 50 stairs to enter their apartment, or their home, and that's just not going to work. So Medicaid's focused also on home modifications to be able to keep people in their homes, regardless of the situation. The next is these caregiver supports. So that includes an increase of respite services from 30 days to 90 days. And then it includes this very exciting and pretty innovative program to support caregivers who are taking care of a Medicaid beneficiary in the home. And it's to provide them counseling services. This is pretty unique because the caregiver does not have to be enrolled in Medicaid to receive those services. And with that has come a lot of challenges. So it's something I've been very excited about for Medicaid to implement. But as of right now, in March of 2026, that program has not been implemented. And there's been a lot of barriers to the implementation for obvious reasons, but we can talk about it more as well. And then nutritional services, this is just things like one-time pantry stocking. So a Medicaid beneficiary who is coming from a nursing home, maybe that's a short-term stay, and then they're transitioning home. There will be someone to help them get stocked and ready to be at home. Also short-term provision of groceries, and then some nutritional education and skills development. So how to shop for groceries on a budget, how to prepare a meal, and healthy meals, and particular meals focused on people, potentially with diagnoses of diabetes or other chronic health conditions that need specific nutritional specifications. Okay, and then just to end, because we're almost at the time to open it for questions, and I would love to discuss with all of you and hear your thoughts on this. But as I said, I know not everyone here is a researcher, so I won't spend too much time on this. But we are really focused on this question of mixed methods. And really what I mean by that is that we're really trying to do some surveys with caregivers. And so our hope is to survey up to 300 caregivers who've been receiving these services for their loved ones and find out how the programs are actually working outside of looking at big data, because primarily our analyses are focused on claims-based data previously, and while we'll still be doing some descriptive analyses and some causal analyses as well to see if MLTSS has these impacts, we just really want to be talking to the caregivers and asking them, how was it to use these increased respite services? Was 90 days a game changer for you? Does that really help you with burnout? I think we're also going to be analyzing caregiver intensity and other caregiving related stress markers to find out if these programs are having an impact, and if so, which programs specifically are having an impact on these caregivers, what is really supporting these caregivers and what is really keeping people in the home. And lastly, I'll also just emphasize that we are going to be adding a merged data set. We're going to be using the NJA choice assessment. So these are the analyses that nurses and care managers go out to the home and they assess the members' living arrangements and also what support services they're already receiving. And this kind of informs what care they're also approved for by Medicaid. And by using that data, it's going to be much more rich. And again, just really deep in our analyses beyond just what claims exist and what you can see in these large data sets. Okay, and I'll stop there and take questions.
Again, I'm Emily Greenfield, and I'm a professor at the Rutgers School of Social Work and also director of our Hub for Aging Collaboration and a proud member of the Steering Committee for Lifelong Strong New Jersey, which is a coalition that I'm going to present on today related to our work toward a multi-sector plan for aging in New Jersey. So in our time together, I'm going to cover kind of 3 buckets of questions. So the first is, what is a multi-sector plan for aging, just in general, not in New Jersey specifically, but just like, what is this thing that we're talking about? Second is, what is Lifelong Strong New Jersey and how did it come to be? And third is, where does the campaign stand today and what are some next steps? Okay, So what is a multi-sector plan for aging at a really high level? Let's do, actually, I'm going to stop sharing just for a second. A quick show of hands. How many of you have heard of an MPA before, are familiar with the idea of it? Okay, that's quite a few. That's great. Okay, so I'll go through this part kind of quickly then. In that case, it'll be review. So let me share my screen again. Okay. All right. So, I mean, even if you're familiar with it, I think it's really helpful to step back for a moment and recognize that multi-sector plan for aging is a 21st century innovation, and that like we didn't have the language of a multi-sector plan for aging 10 plus years ago. It's something relatively new in historical development. And it's also important to realize that this really is state policy innovation. The multi-sector plan movement belongs to state policy. Currently, although there's federal legislation introduced to support and recognize states that are pursuing MPAs, no such federal law exists. It's not coming from DC down to the states like you need to be doing MPAs. This is really something that's bubbled up from state policy innovators in our historical moment. MPAs are really taking a whole of government, as some could say whole of society, even beyond government approach for responding to aging as a focal demographic trend of our lifetime. So we think about like climate change, for example, as being a definitional thing in the life that we're living in our historical moment. Aging, population aging can be considered on a similar level. And MPAs, you know, in terms of what they actually are, oftentimes the output of an MPA is a website with a lot of data and information organized. It could be a PDF, a series of reports, but it's really a plan that offers a 10-year vision. So it's supposed to be long-term aspirational vision that importantly has high-level state policy support. So what makes an MPA different from other state plans on aging is that it has to have the support of the governor's office, like that top executive of our state government, and or state law, like a state legislative act, like an actual law that says, gives some kind of power and authority around the state's MPA. It doesn't belong to any one department of state government. At its best, it's truly cross-departmental, again, this whole of government approach. And it is not just a thing that exists, but really, arguably even more importantly, it is developed in a process that intentionally engages all departments of government, all levels of government, all sectors within the private sphere, and civic partnership, like engaging community members and grassroots advocates who care about the future of aging in the state. Okay, so some examples of MPAs. This one from Illinois is a relatively new one, and Illinois is close to my heart because that's where my own parents are aging in place. And I like this one because it is relatively simple. You know, it's not so heavy of an MPA to wrap your arms around it. So that you can see there's an executive summary and they have 10 priorities. So to give you a sense of some of the priorities, here are some examples. They want to provide more state leadership for age and dementia-friendly communities. So for those who attended the prior segment around state grants for age and disability-inclusive communities, MPA could provide an umbrella tent for continuing and sustaining that kind of state leadership support. That's something Illinois is doing with their MPA. Embedding an aging lens within major statewide public health initiatives, such as on brain health, falls prevention, substance use, abuse, and then launching a statewide comprehensive caregiver awareness campaign and connecting caregivers more intentionally with services through a statewide resource depository that they're creating as part of their plan called Engage Central. A more mature example of a multi-sector plan for aging is from California. This one has kind of the OG. Massachusetts and California are recognized as like the earliest pioneers in the state policy innovation. And you can see California has these 5 bold goals as part of their MPA. It's really common for an MPA in a state to identify like 3 to 6 pillars, that kind of these large categories that they organize the work under. And you can see that they've engaged many, many different departments within their state government, and they actually have an implementation tracker. So you can go on this website, have a database of like, here's what we set out to do, and here's the progress against that goal. So this wonderful report from West Health took kind of a deep dive into the dozen states that have an MPA published. as of July 2025. And I really encourage people interested in learning more about this to look at this report in particular. And it gives you a sense of the breadth of issues that multi-sector plans on aging address. And again, it's really meant to be this whole of government, like expansive population aging approach to thinking about what state policy can do to support the aging of our population. You can also see on this list, health, housing, social engagement, caregiving, transportation, long-term care and services and supports, employment, like this really potpourri of super important focal issues representing different dimensions of opportunities for aging well. Okay, so when we think about the landscape for MPAs nationally, this is again from the West Health website. And you can see here we are in New Jersey. We're turquoise, which we're not at the bottom rung, but we have some ways to go. We also have an MPA Learning Collaborative, so we get a star, so that's good. But we're right here, interested or actively planning for an MPA. So we're on our way. And this is where Lifelong Strong New Jersey comes in. This is the goal of Lifelong Strong New Jersey, is this advocacy campaign, is to move us up one rung and to actually get executive order or legislation in place that initiates a formal MPA for our state. Okay, so what is Lifelong Strong New Jersey today? I mean, hopefully the hope is that Lifelong Strong New Jersey will be the catchy name for what our multi-sector plan for aging in New Jersey is called. Right now, as a precursor to that, it's both an advocacy campaign and an advocacy network. So the goal of the campaign is to get that high-level public commitment for an MPA process in New Jersey, and to also ensure that resources are in place so that the development of the MPA and the MPA itself is robust, is inclusive across New Jersey's diverse and many communities, and also meaningful, that it actually creates the impact that we set out for it to achieve. Lifelong Strong New Jersey as an advocacy campaign is like a coalition. It's an interorganizational coalition and network. Our steering committee is backboned by New Jersey Advocates for Aging Well. I'm not sure if Cathy Rowe is still here with us, but she's our fearless leader of this group. Rutgers Hub for Aging Collaboration is a member of the steering committee that's providing kind of oversight and regular boots on the ground for the work of the campaign at this point. And we also are, very importantly, are working with Mercury, which is a public affairs firm that's really helping all of us kind of push into key decision makers in Trenton to educate and outreach and advocate. Okay, so here are the organizations that are represented on the Lifelong Strong New Jersey Steering Committee with backbone support from New Jersey Advocates for Aging Well. You'll see we have some funders in the mix here, including, and I'm not sure if they're here in our room with us as well, the Grata Fund, Henry Mellon Todd Foundation, Parker. Super important to recognize that this campaign, I don't think, would be possible without private philanthropic support, especially in terms of us being able to secure a public affairs partner to really help us push into state government as a group. It's super important. And also important to realize that Lifelong Strong New Jersey didn't just happen, like it just came out of nowhere. It's actually a reflection of years of working together, many of us working together, and a growing partnership network as well, not just the organizations on the steering committee, but all the, advocates, nonprofit, public, like local leaders who are coming together in the name of this campaign. I think most notably, the development of our age-friendly community work from the ground up, starting with the private philanthropic grant-making program in 2016 in the northern region of the state, really got us talking to each other and connected in a way that we wouldn't have been otherwise. And it's not just with the local community leaders who are very important in this work, but also with kind of the major statewide nonprofits doing work on health and aging, kind of started finding each other through the age-friendly communities work. Like, for example, with the Hub, oops, I don't know what I just pressed. Hold on one second. With the Hub, age-friendly communities was really our foray into working closely with AARP New Jersey, given their support for age-friendly communities. And now it's kind of taken that partnership, for example, through the Lifelong Strong New Jersey campaign. We've also had a lot of age-friendly developments with leadership in Trenton during the time of the Murphy administration, since then Governor Murphy enrolled New Jersey in the AARP network of age-friendly states and communities in 2021, and kind of a trajectory of work with the age-friendly blueprint, the age-friendly grants program coming out of Department of Human Services, Division on Aging Services has also been beating this drum of age-friendly systems change and now participating in this National Learning Collaborative about MPAs as additional foreground for this campaign. And then the national movement is flourishing, right? Like the leaders who kind of started this movement in California, a lot of the private philanthropies, they just keep putting out more good stuff. And the more good stuff coming from the national, like that's fuel for the fire to continue to keep it burning here in New Jersey too. And this is a great website with a lot of wonderful, easy to access resources about MPAs. So doing the work of Lifelong Strong. So it started with our steering committee forming and hiring a public affairs partner. And again, like, you know, I'm a professor at Rutgers. I don't have a lot of experience, you know, how to set up appointments with assembly people to educate them on issues of the future of aging in our state, right? Like this was a capacity that we really needed a partner who's in Trenton all the time, knows how things work to help us navigate and connect with the right people. We also focused early on developing a communications for the campaign. I mean, we know there's so much noise in how people get information through social media, through websites, through e-newsletters, through Zoom meetings, networking, right? So kind of developing our communication, even designing the logo and naming the thing as Lifelong Strong New Jersey was a big early benchmark for our launch. Cultivating a partnership network. So a lot of people in this room, you know, meeting with people and introducing the campaign, asking them to sign a pledge early on for when we had the gubernatorial election, whoever the next governor is going to be, you know, signing a pledge that we want them focused on aging and doing a robust MPA process. This is also a lot of the work. And our coalition met with the 2025, each of them, gubernatorial candidates, like one-on-one Zoom meetings, even before the primaries, like starting to meet with the contenders for the bid and informing them about this work. Since Governor Sherrill was inaugurated, there was a sign-on letter that was written by the campaign and we had about 100 signatures of individuals and organizations asking Governor Sherrill to move forward with the MPA through executive order. We've been meeting with leads of the executive agencies now under the Sherrill administration, key leaders who, you know, need to be in the know about what this is and what it could mean for their work. And we're also more recently meeting with state assembly persons and state senators with the idea that kind of need ideally buy-in and support from both the legislative and the executive branch for a robust MPA process to happen. So we're doing those meetings as well. Okay, so in terms of Rutgers involvement, I mean, there's a lot of strengths of higher education that we bring to this work. I would say we consistently show up. We're active participants in regular meetings that both like the every other week meetings we have with the steering committee members, with the partnership networks, now with the assembly and senators. And I would say our engagement really is like, I mean, could let colleagues here share too, is thinking strategically about this work. Like I think at Rutgers, given that we span disciplines, we're in the business of ideating, like really thinking of how different parts of systems connect with each other or what's possible when it doesn't exist yet. I think we can kind of lend that perspective, like kind of the big picture voice in a lot of this work. We do have expertise in research and data. That hasn't been a huge focus, but we've been able to help refine some of the key advocacy statistics about population aging in New Jersey. And we're also percolating some ideas for a possible data dashboard on healthy aging. That's kind of early and would come once an MPA is in place, but kind of trying to lay the foundations for that. And then, of course, we have a lot of capacity as both teachers and lifelong learners. So being able to prepare PowerPoints like this one and explain to general audiences or mixed audience what this work is about in a relatively short period of time. And we're learning a ton too, like as part of an institution of higher education and learning, we're constantly growing our own muscles. And for example, I personally can speak to how grateful I am for the opportunity to understand how public affairs works in a way that I've never really had an opportunity to be part of before, which is very helpful. Okay, so where is Lifelong Strong now? So we're working on the two paths, both the executive order with the governor's office, the legislation through assembly and senator. Hopefully these things will merge together to have a strong MPA initiation. And hopefully, you know, we can report and engage on the progress of developing the MPA, which involve all of you. I mean, the MPA process really is about listening and asking questions and hearing from people in different parts of the state, different positions to aging, on what their priorities are and what they would like to see various departments of state do, or how they want to partner, and its eventual social impact. So this slide has two ways for people to stay in the know. Invite you to visit the Lifelong Strong website if you haven't already. As soon as you get there, there's a subscribe button on the top right-hand side, or a pop-up that will allow you to add your email to an e-newsletter that comes out about once a month with all things on aging and progress from this campaign. And then also to follow Lifelong Strong on LinkedIn, if you're on LinkedIn as a platform, to get more regular updates that way. So I'm going to stop sharing. Thank you so much for sticking with us for our final 5 minutes. I just have a couple of closing announcements and see you soon opportunities. So we can go to the next slide. I just want to, before talking about what's to come, I want to again thank our fantastic presenters. Really, I couldn't be more proud to be Rutgers colleagues with you all. This was a dream come true and you made it happen. And I found in the breakout sessions I attended, the quality of the content to be on point, cogent, easy to understand, relatively like packing in a lot of ideas in a short amount of time, super thoughtful questions from everybody in the group. And I think it goes to show something we think a lot about with our own work on aging through the hub is that, Rutgers and researchers in general don't necessarily need to be the fly on the wall observers of what's happening on the ground. Actually, there's a lot of capacity we have in higher education to be true partners and co-producers of change. And I think that was a theme across all of the presentations, that this is definitely not research and data just for the sake of research and data, but really trying to be partners on change to make systems and contexts for aging and health equity better in the Garden States. So I just want to honor everybody's work today and always in being part of that. Okay, so for next events coming up, so for our Rutgers friends here, for researchers, those of us who identify as researchers, this could be faculty, staff, administrators, students, postdocs, trainees. We invite you for an in-person event that's going to happen in New Brunswick, regardless of your chancellor unit, regardless of your discipline. If you're doing research on aging or aging relevant research, we have a lunch, a speed networking event happening on Thursday, April 23rd, and registration for that is open. For everybody, for our broad public audience, we invite you to Rutgers Day. Come visit us in New Brunswick. We'll likely have a table both for the New Brunswick unit as well as for Rutgers Health with our partners in the Parker Health Geriatrics Division, planning a table as well on aging on their campus, and enjoy a festival of all things Rutgers, including work on aging there. And then our next virtual event will happen on May 1st. So May is Older Americans Month, and we celebrate it with a kickoff event. And we're going to have a Research to Action Summit on age-friendly communities specifically. So we invite our Rutgers colleagues and the broader public. We can go for the next slide. So this is more about the speed networking event. Rutgers colleagues, be warned, you'll get more emails about this, and we really encourage you to come and have a special occasion to be together in the same room, talking more about our work on aging more broadly. Next slide. So a few final notes. We'll be in touch by email with materials from today. We ask the speakers, if you haven't already, please email us as the organize your PowerPoint file by the end of today so we can get those out promptly. We invite you to follow our hub on LinkedIn and through our e-blast list to stay aware of future opportunities to come together and more about work on aging at Rutgers. And we wish everybody a happy Careers in Aging month. We can go to the next slide. As you exit this space, thank you for showing all the love in the chat too. Just be aware that when you close, you have 3 minutes before 11 o'clock. So when you close out from Zoom, you'll be asked to respond to a few questions in a survey about today's event. We really value your time, your engagement, your thoughtfulness, and everybody coming together in this way.